you still be able to hear me. So today's topic will be about the medical treatment of psychiatric disorders, as well as psychohygiene and psychoprophylaxis. I will give you an overview of this topic because most of the things about the treatment is actually best explored when you are practicing, actually, as well as dosages, such stuff. Because in psychiatric field, rarely you will find the treatment and exact medication which is used for the treatment of the exact illness. And that's the first thing that you need to understand, is that our treatment most of the times is symptomatic. And this is a great art, because the side effects for a certain medication may be the exact treatment needed for another illness, for example. An example of this will be the usage of an antipsychotic as a drug which helps the person to fall asleep. So we are utilizing the sedative side effect. Of course, when we have our hypnotics, a special group of medications used in order to enhance sleep, you may not resort to the antipsychotics as a sedative agent. But you need to understand that yes, you have this side effect, and for example, if you have a person who is entering a psychosis, and they need not only antipsychotic effect, they need not only to get rid of their delusions and their hallucinations, but also, for example, they have troubles falling asleep, then a sedating antipsychotic will be the method you will use for this person. So here is one thing. What else? In psychiatry, we'll use a variety of different drugs from all the fields of medicine, because our patients are usually somatically suffered, somatically challenged. They may have a lot of comorbidities, and that's why we need to keep in touch with other specialists, especially neurologists, for example, or gastroenterologists or endocrinologists as well. As well as know a little bit about other medicaments. But unfortunately, a psychiatrist is not a jack of arms, and we are not able to cure all the illnesses. And this is a problem because sometimes I have seen patients who have come to me after being patients at the neurology departments. And neurologists, for some reason, like to prescribe psychotropes to their patients if they see some kind of comorbid psychiatric illness. But it is not correct to do, because, for example, if I see a patient with polyneuropathy, and this is a neurological condition, I wouldn't try to treat it myself, because I am a psychiatrist. I know how to help the person with hallucinations. I know how to enhance, for example, attention in case of ADHD, but I do not deal with neurological pathology. And therefore, there is a great risk that I will be messing things up. Even if you have been the best student of the best, you know all the different fields of medicine, like your endocrinology, internal medicine, etc., it is best to stay in the field you are in right now, because there is a certain extent of practical knowledge which gives, in this regard, a certain theoretical knowledge which cannot be acquired just from the books alone. So that's another thing. If you see your patient having a comorbid pathology, not from the psychiatry but from some other field, you need to get in touch with the appropriate consultant for this, in order for everyone to treat their own pathology. So I hope you understand this. Also, the treatment in psychiatry can be divided by the variety of methods used. So the basis is always biological therapy, and this includes all the drugs operating the neurotransmitters, for example, all the drugs enhancing our physiology from the inside. Then there is, for example, physical treatment like electroconvulsive therapy, which uses electroshocks, or for example, psychoshock therapy, which uses a certain treatment of psychological extent, which is not very popular. In the past, there were atropine shocks, there were insulin shocks, also surgical treatment. In the past, very popular. Right now, re-evaluated in many countries and not as popular because it has certain side effects, which I will talk about later. And also there is psychotherapy, which is, I would say, at least in Ukraine, I have seen that many psychiatrists have a lot of bias towards psychotherapy. Okay, so the connection was broken. I hope that not everything was erased. So yeah, psychotherapy. In my country, psychiatrists usually have a lot of bias towards psychotherapy because, oh my god, it is so loud. Because in the acute period of psychiatric disorders, the changes in the physiology and functioning of nervous system are so drastic. It is almost impossible to influence and to influence these changes with purely psychotherapeutic influence, because it is always mediated with our own psyche. So when we are using drugs, we are enhancing the behavior from the inside, directly and very roughly influencing our psychophysiology. When we are using psychotherapy, it is usually mediated by our psyche and all the processes already happening in the body. And that's why it may be very hard. I would say that a highly skilled specialist of very high rank can actually work with people in active psychosis with psychotherapeutic methods. But you can imagine how hard it is to find such specialists. Moreover, to use a variety of these specialists on different occasions. So if it is only one person, this person is practically useless, because you cannot use this person for every patient you have. So obviously, for psychotherapy, I would say it is most important in the subacute and chronic periods of the illness, as well as maintenance for the person in order to be socialized and in order to adapt the person with their illness to their life, in order to enhance the life quality for the person. But in acute periods, of course, it is best to be quick, it is best to be effective and very drastic in our influences, and that's why we use psychopharmacology. Okay, so this is the basic overview. We have different types of therapies. We have controlling therapy, and this is what used in the acute period. So we need to control the illness. So we use antipsychotics, for example, intravenously in order to break the psychomotorical and excitement of the patient. Then there is maintenance therapy. Maintenance therapy is all medications used in order to prevent future relapses and exacerbations of the illness, and in order to enhance and diminish symptoms which remain after the controlling therapy. So maintenance therapy is usually management of the illness after the person is being hospitalized, after they are released back to their life. So here is that. Okay. There is also corrective therapy. Corrective therapy is used in order to correct side effects which cannot be improved with the playing with the doses, or for example, if diminishing the dose of the main therapy is dangerous for the patient, for example. So corrective therapy, a classical example of this would be Haloperidol, which is used as an anti-Parkinsonian drug in order to help with the extrapyramidal disorders, following as a side effect the therapy of antipsychotics. And I will be talking about side effects as well today. So here is that. Also, there may be preventive or anti-relapse therapy. So here we are talking about the illnesses which have distinct phases and intermissions. And so here for example, lithium, which is used for patients with bipolar disorder, has anti-relapse properties. It helps to prevent the next phase from happening. So here is that. Okay, what else? When we're talking about antipsychotics, particularly, for example, some of the drugs should be taken constantly. They can be taken in large amounts, and obviously this is not very useful for the patient and not very good for them. Not to mention that some patients may be reluctant to be treated from the very start, and so some of our drugs have prolonged forms, like Modit and Depot, for example. So the patient gets this injection once a month, for example, basically once every 14 or 21 days, for example, if you are talking about Clopixol Depot, which is clozapine in depot form. And therefore, this drug is constantly released in the blood from this injection, and therefore the patient doesn't need to take the drugs orally as often, as well as they usually have less side effects. So another thing you need to understand is that if you need to do something quickly and acutely, it is best to use intravenous form of the drug. And in this case, we can manage the highest dosage of the drug in the blood with the less side effects, because there are no because the influence on the nervous system is almost immediate. Then comes, by the rank of effectiveness, the intramuscular administration. And usually, for example, if we have a patient which doesn't get as much effect from the oral administration as you hoped, you may try intramuscular injection if it is possible. So here is that. The side effect of it, of course, is that you cannot take more than 5 days of these injections because, well, your gluteus will be very hurt from these administrations. But usually, this side effect is managed by usage of warmth. Okay, and the last thing is oral administration. So each of our patients should master at least a certain degree of discipline, because they need to take their drugs very, very carefully without any missing. Not to mention that discipline overall improves the state of the patient. So that's about the types of therapy. Okay, I will be talking about the regime a bit later. So let's talk about what else should I tell you? Yeah, okay. There is also such thing as tolerance to drugs and also addiction to drugs, as well as withdrawal syndrome. So our drugs, when started, should be titrated. So we do not start with the highest possible dosage right away. Sometimes we do not start with the minimal dosage right away. We gradually build up the concentration in the blood. And certain types of medicine may require certain tests to be done on the blood in order for us to be sure that we are remaining in the therapeutic window and that we are not poisoning our patient. This is done because, unfortunately, some drugs may cause allergies. Some side effects should be best tolerated when the person is introduced gradually to them. And as you can understand, rapid discontinuation of the drugs usually doesn't show any good for our patient. In the least dangerous episodes, I would say it would only give the patient the relapse of their psychotic symptomatics. In the worst cases, unfortunately, the withdrawal symptoms of, for example, cholinergic effects of, for example, kicking in of the dopamine system, etc., or kicking in of the serotonin system, they may be fatal in some cases. And in these cases, of course, you understand that rapid discontinuation is not the way to go. Gradually increasing the dose and gradually decreasing the dose. In cases when we need, for example, to switch from one medicament to another, it is very important to use cross-titration. So it depends on the certain drug, but I will give you an example. So for example, the patient is taking one antipsychotic and we need to give the patient another antipsychotic. This antipsychotic doesn't do any good. So we start to titrate this first antipsychotic down. So we are lowering the dose very, very gradually. And when there is, well, roughly about the half of the dosage the patient was taking before, we can introduce the half or even less the dosage of the new antipsychotic. And then the new is being raised gradually and the previous one is down to titrate gradually. Once again, this helps to avoid the breaks in therapy, which are crucial in a variety of other diseases, because there is schizophrenia when the person loses critics to anything. There is bipolar disorder when the patient can fall into depression or in mania and lose all control. Such stuff. When we have tolerance, so our nervous system is constantly adapting to the medication we give our patients, and sometimes the patient may become tolerated to the effect of the drug. Well, one way is increasing the dose, but when you increase the dose, obviously there is a higher risk that side effects will become unbearable. Not to mention that some drugs are toxic beyond certain dosages. So in order to avoid this, sometimes we practice withdrawal syndrome, which is induced artificially. So we take away all the medication in order to enhance sensitivity of the receptors, and then we continue the treatment anew. So this can be done, but only in the conditions of the hospitalization, of course, because we need to manage if there are dangerous complications of this. Also, sometimes electroconvulsant therapy helps, and when I will be talking about electroconvulsant therapy, I'll tell you some things why. Okay, and what else? We talked about this. So yeah, another great thing is always about the duration of treatment. The basic duration of treatment when we are talking about, for example, neurotic disorders is half a year. And then we'll see if the patient can live without the drugs that. For other chronic conditions, it is up to a year and indefinitely, especially if the person has had multiple episodes of psychosis throughout their life. So here is that. Many people prefer to take psychopharmacological drugs and not worry about anything. But this presents us with a lot of problems, because you need to have a constant source of your medication. Because you are not addicted to your medication physically, you're not addicted psychologically, but economically. And if you do not have anything else to rely on except your drugs, in cases when you have no access to your medication, well, you will be screwed, basically. So psychopharmacology is very good in acute period, in order to roughly and quickly help the person. But in long-term conditions, if we cannot be sure that you constantly have saved amount of your medication for yourself, you cannot rely fully on it. So that's why I was talking a lot about psychotherapy. So psychotherapy helps the patient in the long term. It teaches the patient to manage the remaining symptoms and their state, and to continue to have the critics on if something happens. If for some reason you missed the pill, or for example, for some reason you cannot buy more. So for example, in Ukraine there is a war right now, and all my patients were left basically without medication, and we had to manage their psychosis, their illnesses without it. And well, I'm working with a psychotherapist in a pair, and luckily that psychotherapist is of very high level of skill. Oh, it stopped showing anything. Yeah, so I'll finish this speech and then I'll ask if I need to go away so that people will get the access to the washing machine. Okay, yeah, so in long term, you shouldn't rely on the pills alone. In long term, psychotherapy is a thing which will be very, very, very helpful. But as always, if you have access to many different ways to influence your illness, it is best to rely on all of them, to use all of them, anything you can use to help your patient, and not just say that, oh, psychotherapy doesn't work, or for example, oh, psychopharmacology doesn't help, all these patients have problems psychological. No, it's always from the two paths. Yeah, also about psychotherapy, that was the thing what I was saying, why many psychiatrists have bias towards it. Because most of the techniques in psychotherapy were made and approved for patients which are not psychiatric patients. So basically people who have no illnesses. And for our population we are working with, we need to have specific methods. Lately I have seen that these methods are being tested. For example, metacognitive psychotherapy, which is used for the patients with delusions, but they're not as popular, and well, in Ukraine at least, most people haven't heard about such methods. So that's what I needed to tell you, that when you are choosing what kind of therapy you're using for your patient, you need to understand what is the goal of the therapy, so long-term, short-term, what you need to get. You need to take into account the financial situation of your patient, because even among pills, there are different pills with different effectiveness, with different price. And you may suggest your patient the best pill possible, but if it is too expensive, the patient just won't take it. So you need to take this into account. And also the kind of an illness you are dealing with. Sometimes psychotherapy is preferred when it is a neurosis, for example. And sometimes you cannot go without psychopharmacology, like in case of psychosis. So that's why I told you that it is an art and it is very, very hard to understand. Yeah, also about types of drugs. You may have particular names, for example, antidepressants, antipsychotics. But especially antipsychotics, these medications usually have an effect on different receptors. And it is more important not to think about them as a group, but to know their mechanisms, at which receptors they have their effect. Therefore, you'll have more luck with comorbid medication, for example, from other specialists, if you know at which receptors they give their effect. And you have a little more versatility when you are working with our patients, because you know that you need to influence a certain type of receptor. And maybe the drug you're looking for is not in the group of antidepressants, but maybe it is an anticonvulsant, for example, or maybe it is a soporific. So you'll be more flexible in your choice if you rely not solely on the groups, but on the very effects of the drugs. It may be very hard at first, but there is a way to remember all this, and especially if you are a practicing psychiatrist. Obviously, I want to ask this from my students on the final lesson, because not all of you will be psychiatrists, but still, when you're practicing, this will come to you. So it is not as hard as it seems. Not to mention that, well, psychiatry is a very broad field, but not very big still, in my opinion. So it is not as hard as it may seem. Okay, so 1 minute, I'll check if they need to get the access to the washing machine. 15 minutes. Нет, я ухожу. Да, все. В общем, пока оно там летит.
Ты уже не работаешь?
Нет, я работаю. Сейчас я телефон возьму здесь и все. Okay, we can continue. It was just a very, very little break here. Okay. So, our psychoactive substances, oh, thank God it is quiet. Okay, so all psychoactive substances which are used in psychiatry can be divided into groups such as neuroleptics, tranquilizers, antidepressants, chemostabilizers, psychostimulants, and also nootropes. Anticonvulsants are also used, but anticonvulsants are mostly neurological drugs. So, as I have said on the previous lessons, we only deal with people with epilepsy when they develop psychiatric disorders. So, once again, for us, the main therapy is in the field of psychiatry still. And anticonvulsants are just adjustments to our therapy. So here is that. Also, the research group called, psychodysleptics or or psychotomimetics or hallucinogens or psychedelic drugs. And they are not used for the treatment just yet, but they are used in the research. And in our country, in Ukraine, they are prohibited from the usage. Okay, so about neuroleptics. So their main field of action is on the dopaminergic system, because the excesses of dopamine cause the development of delusions and hallucinations. So they are also called antipsychotics. And basically their intended usage is to get rid of productive psychotic symptomatic. Productive, and that's important because unfortunately a lot of negative symptoms mirror the side effects of neuroleptics. Okay, in small dosages, neuroleptics can be used in neurotic disorders. For example, the antipsychotic called quetiapine has sedative properties and is used, for example, sometimes to enhance sleep in people with anxiety. And also, for example, if you remember, there is such a syndrome called geriatric syndrome. So in this case, we use haloperidol, which is also an antipsychotic, but we need it not for the property of getting rid of delusions of hallucinations, but we need its relaxative thing. It prevents the tics from happening. Okay. So what else? Basically, neuroleptics have a variety of receptors at which they act. So not only the dopaminergic system, because it is the intended usage, but also muscarinic receptors, also acetylcholine receptors, also histamine receptors, adrenergic system, all of those. And therefore they have maybe the most complicated mechanisms of action out of all other groups. And these mechanisms are connected to the variety of side effects we can get with these drugs. So there are many different groups, but I need to tell you, for example, there are three main groups of neuroleptics based on the effect. So there may be primary sedative effects like ammonazine, tizicine, and haloperidol. There may be neuroleptics with general antipsychotic properties like 3-fluoperazine, haloperidol. There may be neuroleptics with the stimulating components, so for example, when the person needs to be stimulated. So metarazine, perfenazine, franolone, sonapax, egonil. Also, the main side effect which we all fear from the neuroleptics is extrapyramidal disorder, because the dopamine system not only has a way to go in the psychotic symptomatics, but also in the movement coordination, in the substantia nigra. So unfortunately, the typical or the first generation of antipsychotics were causing a lot of problems with movement for our patients. So their faces were becoming as masks. They had this sensation of being bound. There may be symptoms of not being able to sit still, for example, for this patient, the changes of their gait. So all those are extrapyramidal effects. The atypical antipsychotics, on the other hand, their side effect of extrapyramidal disorders is diminished almost to the non-existence. But they have another problem. They cause a lot of side effects on the heart, such as arrhythmias, the prolongation of QT. Also on the secretion of prolactin, so they make the prolactin go up. And also other metabolic changes, such as the change of the weight of the patient, sedation, and also an increased risk to develop diabetes mellitus. So as you can see, the typical and the atypical antipsychotics differ by their side effects. And also typical are usually more, they also cause a lot of hypertension in the patients, and they're usually not well handled by the elderly or people who are children, for example. So when we're choosing atypical ones, we are aiming at less side effects, less mortality, and bigger, but also bigger risk of metabolic syndrome. So here is that. Okay, so just to be brief on the particular treatments from this category. For example, ammonazine was the first psychoactive drug, very pronounced hypotension. So patients who have been administered ammonazine need to lie down for 1 hour after being administered, in order not to get down. Also another thing, and this actually pertains to all the medications we use in psychiatry. So most of our medications are metabolized by liver and can have a certain effect on the liver ferments. So they may enhance and make the effect of these ferments stronger, or they may make these ferments weaker. And this is another thing you need to know and to think about when you have multiple medications going at once in one patient. Because you may use the lowest dosage possible, but for some reason of interaction between these meds, their blood concentration will go up, for example, to the toxic level. So that's another thing you need to know. And also, kidneys are used to excrete our medication. And this is also important because, for example, right now I have a patient who suffers from nicturia, and she goes to the toilet 20 times a day. And this is a very big problem because she also gets therapy of gabapentin. But gabapentin is excreted by kidneys all the time. So she just excretes it all the time from her organism, and we get no effect because it just doesn't have time to kick in because she's constantly going to the toilet. So here is this. Also, another drug from the antipsychotic family is haloperidol, for example. Has potent sedative effects, so it is to go when you have psychomotorical excitement, but it is very effective, and you need to use very small dosages of it. It is contraindicated in organic lesions of the brain with Parkinsonism-like disorders, because unfortunately the extrapyramidal effect of haloperidol is very, very strong. In my hospital, it is said that haloperidol is the drug to kill the tank because it is just so strong. Also, flufenazine. This is one of those depot preparations, so intramuscular antipsychotic. Can be given once every 23 weeks and manage the patient's psychosis. Okay, what else? Yeah, clozapine. Clozapine is used in treatment-resistant cases of schizophrenia. Very potent sedative effect. It reduces aggressive behavior, both self-aggressive and aggressive. This is very important for the therapy in many cases. But you shouldn't, once again, rely too much on this medication, because, for example, in my hospital, the head of the ward always loved antipsychotics. It was her favorite drug for the patient because it was so effective and it was also very cheap. But the problem is that this month, and probably from now on, the hospital won't buy this drug, so there will be no azolipine. And you should have seen her face when she recognized that there will be no azolipine, because she was dependent on this particular drug. So now we had to think which other drugs can substitute azolipine for its properties. That's why I told you that you need to know about mechanisms of action. Because if you need sedating effect, there is a variety of other sedating drugs. The only problem is with the aggression. But aggression can be managed by other means, by psychotherapy as well. So we need to think about it also. Okay. Yeah, also about antipsychotics. Atypical antipsychotic like clozapine can cause agranulocytosis very often, especially clozapine. And this is what we fear. So when you administer antipsychotics, you need always to measure the weight of the patient. You need to check the blood, the sugar in their blood. You need to check the function of the liver and also the level of the white cells in their blood. Because if you don't need to have the impairment of the immune system because of our medication. So here is that. Also, tizatine, very potent anti-anxiety effect, often administered at night. Haloperidol also removes anxiety, fear, and restlessness, but doesn't cause severe sleepiness. So it is a very balanced drug. When we're talking about pyrazine, it is a behavior corrector. It is mostly used for the psychopathic behavior, so it removes the impulsivity of the patient. Also, tioridazine, mainly for non-psychotic disorders, also suppresses sexual activity, and it is also very important because unfortunately some of our patients are very disinhibited in the sexual activity. Also, clopixol So specific inhibitory and non-specific sedative effects. So yeah, that's why I had my mistakes. So Clopixel is Zucopentixel, and clozapine is clozapine. Unfortunately, sometimes brand names and generic names of the drugs are not as recognizable, and I may get very perplexed in them. It goes away with practice, always, so I think that I'll get used to it, certainly. Okay. Yeah, about Zucopentixol, it doesn't have, it has a transitory dose-dependent non-specific sedative effect. So it is advantageous to treat acute psychosis. And this is another interesting thing, is that at small dosages, some of our antipsychotics can be sedating, but at high dosages, it is be more antipsychotic. So that's what we need to take into account as well. Also, there is Flupentixol. Okay. What else? Yeah, mostly used for depressions. There is also sulpirid. So it has the best effect in mild depressions. Olanzapine is good for the acute forms of schizophrenia and other psychosis, but is also very expensive. So it is not used in our hospital, for example. Also, there is risperidone, very popular drug, especially for children, for treating their psychosis. But unfortunately, it has a certain effect on the cognitive abilities, so it dulls the thinking ability a little bit, and our patients usually don't like it. Okay. So now, there is such a group called tranquilizers. Tranquilizers are used in case the person has anxiety, listlessness, sleepless nights, etc., insomnia. So they used most often in the neurotic kind of disorders, but can be used as well in the treatment of acute states such as delirium, for example, and as adjuncts to other types of treatment. So most of the tranquilizers act upon the excitation of benzodiazepine receptors, which cause the activation of GABA system, which just diminishes the excitation of our nervous system. The drawback of this effect is that these drugs most notably cause dependence if administered more than 2 weeks. And therefore, when you try to cancel them, you need to be extra careful, because now you have not only physical dependence, but also psychological one. And this patient who is taking gabapentin, for example, she is psychologically dependent on diazepam. She constantly begs for diazepam. She doesn't even feel nervous anymore, but she needs diazepam. That's how she feels. Okay, so the groups in tranquilizer group. Groups of drugs include agonists of benzodiazepine receptors such as diazepam, phenazepam, or diazepams. Also agonists of serotonin receptors such as buspirone, campron, and substances with different types of effect. For example, benactizine. And also, well, those are mostly soporifics, but there is a certain group of 3 drugs called zolpidem, zopicon, and telipon, which are also called Z drugs. And they have benzodiazepine-like effect. They are administered at night, and especially in intermezzos, when the person just pops awake at night and cannot fall asleep once again. They lower the arterial pressure very low, but they help for the person to get asleep. And unlike other soporifics, for example, which cause up to 8 or 7 hours of constant sleep, or even 20 hours of constant sleep, these drugs only help to fall asleep, because in 3 hours, half of the drug is already out of the blood. So that's how they use. These drugs are very, very cool. Okay, so now about tranquilizers. So one of the most famous one is sibazon or diazepam, which is usually infused intravenously in acute agitation of the patient, helps to control delirium, acute anxiety, convulsive seizures, and dysphoria. Can be orally used for neurotic anxiety. And as you know, all these tranquilizers, they shouldn't be combined with alcohol, because they can get the person to experience extreme intoxication and sometimes even die. Also, phenazepam is originally Ukrainian drug preparation. There's also helenium, which is mostly used for annoying thoughts, hypochondria, anxiety, and unfortunately can cause cerebral ataxia and also listlessness. Okay, there are also such drugs as nozepam, alprazolam, and yes, another thing which I needed to tell you is that all the tranquilizers can be divided into daytime tranquilizers and nighttime tranquilizers, because those which are very sedating and which cause different changes in the attention of the person, in awareness of the person, which should not be taken while driving, should not be taken during the day. So nozepam, for example, delays reaction, so it is a nighttime preparation. So here is that. But for example, there is alprazolam, so it usually is more of the daytime. Also diazepam, also tranquilizer with activating effect, but it is also used during the day and not the night. There is also hydroxyzine. Very good for the feeling of fear in elderly patients, in chronic alcoholism, and with express psychomotor excitement. Okay, so also there is Mebica, has mild hypertensive effect, mild analgesic, antidepressant, and activating time. One of the daytime tranquilizers. Okay, buspirone, I have talked about it basically. Okay, now let's have a little break, then we'll continue.